Bill from Georgia.
Conference record has joined the conference.
So we had a gentleman from Georgia.
Bill from Georgia.
Great, Phil.
That's Sydney from Colorado.
Good morning.
Britain from Madison.
Good morning.
Barbara from North Carolina.
We're covering a lot of geography today. I love that. North Carolina, go ahead. I'm sorry, who else?
Pat Harvey, I'm on the line.
Oh, good morning, Pat.
Hi,
and
Ken.
welcome. And
Thanks.
I was just, before you joined, I was just asking, we have folks from many states is what I would say on the call. So
Great.
The popularity of you and this topic are not lost on the NAMI audience. So,
and this is Britt Rathbone, also from Maryland.
Excellent, Britt. Good morning.
Good morning.
This is Brian from Montana.
Great.
Carrie in Austin, Texas.
Good morning.
Kim from Oneonta, New York.
Good morning, Kim.
Morning.
So I'm going to ask the person with the lovely young child to hit *6 to mute themselves, and when you have a question, hit #6 so you can ask a question. So we have at least 30 or 50 people on the call based on the number of beeps and the number of people who've introduced themselves. More will probably join. So just for our speakers, if you hear a beep in or a beep out, that's a person who's joining or leaving the call. You can ignore that and keep going. I just ask people, because of the informal and slightly chaotic nature of the Friday call, to do your best to keep it quiet or stay on mute so that the sound quality is better for when we record it. So I'm delighted to continue our conversation on helping adolescents with self-regulation skills. We've had Blaise Aguirre, of course, on the Friday call, and today we're very fortunate to have Pat Harvey and Britt Rathbone, who will be speaking about the use of DBT in the adolescent population. So I'm going to let you take it away, introduce yourselves a little bit, but I do want to say we're always grateful for giving your expertise to the NAMI audience, and we hope to continue to have the two of you back as you continue to do your work and learn, because this is obviously an area that is, I would say, a growth stock in the field and is obviously quite important to us all. All right, well, thank you. And so, Pat and Britt, I'm going to let you take it away. And so what I usually ask the experts to do is speak for 15 or 20 minutes to organize our discussion, and then we have a Q&A of a free-for-all nature. So with that, let's go, and thank you again.
Our pleasure. Thank you. This is Britt, and I'm going to start and kind of orient you all to what dialectical behavior therapy is and how we apply it to adolescents, and then Pat's going to talk specifically about a skill that we use with parents of teens who have intense emotions. So dialectical behavior therapy was initially developed, as you probably know, to work with suicidal adults. So it was developed for a very high-risk population, and then it was expanded to borderline personality disorder, which was and is still, I believe, the highest fatality rate in terms of psychiatric conditions outside of anorexia. So it's a treatment for people who have very severe problems with mood regulation that can sometimes result in death. So it's a very serious set of symptoms. And the fact that it worked with suicidal adults and worked with folks who have borderline personality disorder, which is a condition of mood dysregulation and impact on social functioning, made it a perfect fit for adolescents. And Alec Miller and Jill Rathis did research on applying it to adolescents and did a randomized controlled trial study that showed that it was effective with adolescents as well, suicidal adolescents. And now what's nice is that it's been applied and integrated into programs with eating disorders, rigid and over-controlled behaviors, and even behavioral problems. And there are DBT programs now integrated into some of the prison systems in the country, which is interesting. So it's a treatment that is effective, more effective than other treatments for these kinds of symptoms, and works nicely with adolescents. Now, what is unique about dialectical behavior therapy is that it really takes cognitive behavioral approaches, which is looking at the way people think and the way people behave and sort of how that impacts their emotional life and how they reinforce one another, and added in an element of acceptance, which is frankly missing in a lot of cognitive behavioral therapies. And so we'll talk a little bit about that as we move through this. But that is sort of kind of the unique element of DBT is that it addresses the dialectic meaning that you can have two things that appear not to be consistent or cannot exist together, and they can. And that's the case here, that we focus on accepting the adolescent as they are, and at the same time we focus on changing the adolescent's behavior. And that's kind of a unique element of DBT. What I'd like to do is just give you a brief summary of what DBT looks like. There's a lot of folks who say they're doing DBT in the community, and they may be bringing in elements of DBT but not doing all of DBT. And so I want to go over what DBT really looks like when it's being done comprehensively. So what's unique about DBT is that we do separate skills training with adolescents and parents, teaching them a set of psychological skills. And these psychological skills have to do with several categories. The first of them is mindfulness, which is learning to pay attention to the moment without judgment, which allows folks to kind of slow down and respond in an effective and strategic way rather than an emotionally driven way. Another section of skills is interpersonal effectiveness, which is learning how to get your needs met with other people in a way that keeps the relationship alive and at the same time doesn't sacrifice your self-respect. Another set of skills has to do with emotion regulation, which teaches folks, parents and adolescents, why we have emotions, what the purpose of emotions is, and how you can live with having intense emotions, and what you can do to kind of live a life that makes you more functional given that you have intense emotions. We teach a set of skills on distress tolerance, which is how do you cope when you feel like doing something drastic and impulsive that could harm you. And so it's this whole set of skills around distracting yourself from stimuli or managing that stimuli in such a way that you don't hurt yourself. And then there's another set of skills called Middle Path, which was developed specifically for parents and adolescents. So this set of skills does not exist in adult DBT. And that set of skills talks about validating one another, parents validating kids validating parents, kids validating themselves, and parents validating themselves. It teaches dialectics, the concept that you're going to get out of black and white thinking and try to see the synthesis. And also teaches some basic psychological skills around behaviorism. You know, what is reward, what is punishment, what works best, and how to shape behaviors. So all of those skills are taught typically in a group. And kids and parents are being taught the same skills, and they're practicing those skills at home with one another and also with other people in their lives. Additionally, there's individual therapy. So you have one session a week of skills training and then another session a week of individual therapy. And the individual therapist's focus is on applying these skills to the adolescent's life. So they're learning the skills in one setting and then they're having it applied or they're being assisted in applying them in a different setting. And in the individual therapy, the therapist focuses on symptoms in a very focused way. So they always target any behaviors that could result in death, so that would be suicidal ideation and behavior, self-injury, et cetera. That would always be targeted first. Then they always target any behaviors that interfere with treatment second. Those would be things like coming to sessions late or not showing up for meetings or not doing homework assignments or not tracking behavior on the daily log. And then they always target quality of life behaviors last. So the focus is on maintaining life, keeping the person alive, number one, maintaining adherence to treatment, number two, and then ultimately working on the issues that get you into therapy. Then we also, so those are two pieces, skills training and individual therapy. Then there's also coaching in the environment. What that means is the therapist is typically available by cell phone to interact with the adolescent in the moment as necessary. So if you think about most people, they go see a therapist and they spend 45 minutes or 50 minutes with them once a week, and then that's it. And then they have to go out and live their life. And what DBT offers is availability to the therapist in the moment. The idea being that we want to be able to reinforce and coach the use of a particular skill when they need it, when they're at the party, when their boyfriend or girlfriend just broke up with them, when they just had to fight with their mother or father, to encourage more skillful behavior and to prevent behaviors that are self-destructive. Then Pat will talk to you more about what's called consultation to the environment, and that's working with parents and working with school personnel and other treatment team members, psychiatrists, et cetera. And so I'll leave that for Pat. And then finally, there's a consultation team. And the consultation team keeps the therapist focused on delivering the treatment in an effective way. So it can be challenging sometimes for therapists to work with young people who are chronically suicidal or self-injuring, and you want to keep the therapist's motivation level up, and you want to keep them working in a way that's effective. So the consultation team provides that support and guidance for the therapist as well. So I'm going to turn it over to Pat now, who's going to talk about how we work with parents specifically in DBT and how we balance the acceptance and change philosophy when we're doing that.
Okay, thanks. Okay, so for parents and for family members and for caregivers, living with a kid who has a lot of emotional dysregulation is really difficult, and very often parents get caught up in what I sort of call the emotional vortex of what's going on. And what really we have to recognize is how does a parent slow down their response time so that they can respond in a way that's going to ultimately be effective. And what does effective mean? It's going to de-escalate the situation. It's going to help your child or your teen sort of move forward without making the situation worse. So the question for parents is, how do we take sort of the DBT philosophy that Britt's talked about of acceptance and change and use that with our kids? And also, how do we structure the environment so that it is reinforcing and responding to the healthier behaviors and reacting and responding less to the unhealthy behaviors? And we all know that kids that have mental illness, emotion dysregulation, get us sucked into responding to their unhealthy behaviors because we're so afraid that if we don't respond, what's going to happen? And yet what happens very often is that when a teenager is doing what they're supposed to be doing, we sort of take a breath and stand back and say, great, I don't have to be involved right now. When in fact, structuring the environment means being able to respond to those healthy behaviors even more so and reinforcing even more so than we do the unhealthy behaviors. So that's one of the issues about structuring the environment that's present in schools as well. Schools tend to respond and react to the unhealthy behaviors, and they don't necessarily respond when kids are doing what they need to be doing. For kids with emotion dysregulation and mental illness, doing what they're supposed to be doing is really, really hard, and we have to be able to acknowledge that. The way that we look at behaviors in DBT, the behaviors that get our kids in trouble, whether it's aggression, substance abuse, cutting, suicidality, overdosing, it's really about ways that kids have found to manage pain. It's not about attention seeking. It's not about being manipulative, although it sometimes may seem that way to parents. It's not about just doing things to get back at people. It really is that the kids are in pain. And if parents can remember that, it sometimes is easier to respond in an effective way and not get caught up in being angry at your teen for doing things that are, to them, ways that they're trying to manage their pain. So I ask parents not to make judgments about their teens and also not to make assumptions about why they're doing what they're doing. You're only doing this for attention. You're only doing it because your friends are doing it. You know, those kinds of things, what they do is they wind up getting parents angry and disappointed. And that increases parents' emotionality, which makes it less effective. So what I talk to parents about is slowing down, taking a breath, And in terms of acceptance, thinking about two things. One is your child, your teen, is doing the best he or she can in this moment given the context of his life or her life. Which means that in a sense that we think about the fact that even if our kids are having a really, really difficult time, right now in this moment, this is the best they can do. They may be able to do better at other times. They may be able to do great at other times. But at this moment, this is what they can do. Again, that lessens parental reactivity. Now, the corollary to that, that's the acceptance piece. The change piece that Britt talked about is, and your child has to do better and be more motivated to change those behaviors that are getting him in trouble so that your teen can have the life that he or she wants to have. So that is the acceptance and change that I teach parents. Your teen is doing the best he or she can at this moment in time, and he or she needs to do better in order to have the life he or she wants. The way that translates for parents is that what you have to be able to do when your teen is having a really hard time or is emotionally dysregulated is validate and acknowledge what your teen may be experiencing. So that even if your teen is screaming at you that you are the worst possible parent in the whole world, what you need to do is be able to recognize that underneath those very hurtful and painful words is somebody who's pretty angry. And if you can acknowledge the anger and take your child's anger seriously and understand that for him or her something is actually really going on and acknowledge that, that tends to, and Alan Frazzetti has done a lot of research on this, it tends to de-escalate the situation and actually allow your teen to talk to you a little more. Now, that does not mean that you necessarily agree with your teen. It doesn't even mean that you like the behaviors that your teen is doing. It means that you get that there is something emotional going on or something going on for your teen that is causing them to behave in this manner. And I always use and, not but, because we think dialectically, and dialectically means we think in a variety of different contradictory ways. Your child is doing the best he or she can, and he or she has to do better. And I get why you're behaving this way. I get that something's going on with you, and you're really hurt and you're really angry. And there's a level of abuse that's not acceptable in this family. And that if you behave that way, then we are not going to be giving you the privileges that you want. And so what DBT talks about is this dialectic of you accept that your child is doing the best he or she can, and you also are willing and need to set expectations, set limits, and then observe those limits. So if you tell your teen that behavior cannot occur in the house, and then it occurs in the house, you have to be ready to observe limits about that. And so that is the acceptance and change. Now, for the parents that I work with, validation
can you hold on just 1 second? Could a few folks please hit *6 to mute you? It just helps us all with the quality. Thank you so much. All right, Pat, sorry for the interruption.
That's okay. So one of the most important things that parents can do is learn to listen to what their kids are saying to them. And I've worked with a number of parents over time for whom this skill has changed everything in their families. When they started to listen, to understand, to take their child seriously, to follow through on some of those expectations, that has enormously changed their families, as well as then setting appropriate and effective expectations around that and responding to the healthier behaviors. The parents that I work with now say that even more important than validation is the skill that Britt talked about and that I already mentioned. You have to be able to slow down. You have to be able to take a breath. You have to be able to sort of think through what your response will be so that it's an effective response and not a reactive emotional response to your kid. Because if your kid is emotional and you're emotional, that will escalate the situation and only make it worse. So validation, change, and slow down, and that's our message for parents. Okay? And now we are open to questions.
Boy, that was a nice summary of both the field and some quick strategies. So I'm going to ask people to do is pay attention to their mute button. If you have to do anything else, please hit *6. But to ask a question, hit #6. And if you're comfortable with it, say your name and ask a question, and let's take it away. We have till noon.
No, but is it muted already? I think it's muted already.
No, I think we can't hear you there. So if you would hit *6, that'd be beautiful. Anybody have a question for Pat or Britt on the use of DBT in adolescence? Strategies for parents.
Well, I'd like to ask a question. My name is Marjorie Green, and I have a daughter who will soon be 18. She's in a residential treatment center right now, and hopefully will be coming home. And I'm wondering where an adolescent of that age falls in terms of the approach with dialectical therapy. Would she be more in the adolescent category? Would she qualify for adult DBT therapy? I'd love your thoughts.
It's a good question, and it raises sort of the unanswered question, which is when does adolescence end? We always sort of handle that individually. But I like to use the idea that adolescence is over when you've established your own identity and you've separated from the family from a developmental perspective, because it's clear when adolescence starts, it's with puberty or prior to puberty a little bit, but when it ends is a little trickier. In our program, 18, we would consider 18 fully an adolescent. Now, if this was an 18-year-old who was living independently, was working or functioning in some kind of independent way, wasn't dependent on their parents, we might look at it differently. But I think the key in terms of your question is the treatment might get planned out a little bit differently. So, for example, she might be in a skills group with other, 18 and 19-year-olds as opposed to being in a skills group with 13 and 14-year-olds, for example. That would be a better fit for her because the issues that are coming up that they're talking about problem solving with are going to be more age appropriate.
The rest of the treatment is the same. It's developmentally related to where she is in terms of any treatment. But in terms of the protocols in DBT are the same protocols. The therapist has to be part of a consultation team. There has to be skills training. There has to be individual therapy. All of that is the same, whether it's a young adolescent, an older adolescent, or an adult. That's the beauty of DBT.
This is Ken. I'd like to ask a related question. One of the changes that people often ask about are the laws around information sharing when people turn 18, or in some states 19, and assume responsibility for their medical care and de facto their medical records. How do you think about that in this context?
Well, we're in Maryland, and in Maryland, actually, it's 16. It's the age of consent or confidentiality for mental health care. Mm-hmm. So there's the law, and then there's the relationship you have with the young person or the young adult and getting their permission. We find it works best if the adolescent trusts the therapist enough to allow the therapist to interact with the parents, with or without them present. So there's the law piece, and at 16 and up in Maryland, it would be you couldn't do it. You couldn't share that information without the adolescent's permission, but I can hardly think of a time that the adolescent hasn't been willing to give permission once they get comfortable with the therapist in the treatment process.
Based on the strength of your alliance.
Right.
And I think it's also important, one of the things that we have going on here is that I actually work only with the parents. And part of the reason I do that is so that the parents themselves can have the support that's really theirs, and not just as an adjunct to the therapy that their adolescent is doing, but also because I get to help the parents do the limit setting. It actually protects the relationship between the therapist and the teen, because we know how hard it is to develop trust and how difficult it is for adolescents. So because I'm working with the parent and I'm helping the parent set up the guidelines and the expectations, the teen doesn't get as upset with their own therapist for working and talking to their parent as much. In terms of safety, we all share that information. And if a kid is unsafe, then that is information, obviously, that breaks confidentiality. Imminently unsafe.
So my name is Barbara, and I have a question.
Sure.
Go ahead.
Yes. What is the difference between the DBT and cognitive behavioral therapy?
So DBT, dialectical behavior therapy, is a form of cognitive behavioral therapy. So Cognitive behavioral, there's many ways you can do cognitive behavioral therapy, and DBT is one of those. What's unique about it, and I think, and I alluded to this earlier, is it does bring in this whole concept of mindfulness, which is acceptance, into a very change. Most cognitive behavioral therapies are very heavily focused on change, and one of the complaints sometimes that consumers have about cognitive behavioral therapy is that they feel it's a little invalidating. You know, most people, when you think about your own, all of us, you know, when we want to make a change in our behavior, there's typically some resistance and ambivalence to making that change. And so cognitive behavioral therapy is very effective when people are ready to make a change. You know, if they say, look, I'm ready to get over my fear of being on an airplane because I got a job where I have to be on an airplane consistently. There's high motivation. But we don't get that level of high motivation typically with adolescents. And people who have these conditions that bring them to DBT have typically gotten some reinforcement through people around them and their schools and their friends and other areas for the problem behaviors, frankly. So there's some ambivalence about giving up these problem behaviors. And even if you think about self-injury, for example, self-injury, people report, and we believe, and it's clear, that self-injury does help relieve pain. So DBT acknowledges that. It acknowledges that we accept that you have a system for relieving pain that's very effective for relieving pain, and at the same time, we are focusing on changing that particular method for relieving pain because it has consequences in addition to relieving pain. You know, there's negatives to it as well. So DBT is a cognitive behavioral therapy, and what makes it unique is this addition of acceptance or validation, in addition to the focus on change.
Thank you.
This is Bill. Would you recommend that that parents of adolescents that are in DBT therapy get involved with taking the program that Dr. Frizzetti and Dr. Hoffman created through the
Family. You're talking about Family Connections?
Yeah, Family Connections.
Yeah. I think it's really important that parents do a couple of things. One is that they know the same language of DBT that their kids know, okay? Two, that they have a way to learn validation and the other skills that are really helpful. The other thing I think that's really important is the idea that parents talk to other parents. I do 2 parent groups, and one of the things that they're talking about a lot is how they don't feel isolated anymore, that they understand that there's a tremendous power in talking to other parents who get it, who really, really get it in ways that a lot of other people don't. The other thing is I think that there is also a very important message that you give your team when you say, I'm going to learn some new things as well. That you're modeling the fact that all of you are in this together and that it's important enough that this is not just something you're telling your team to do. It's important enough that you're doing it as well. So the benefits are tremendously, are just tremendous. And I've known a lot of parents over the years that have done Family Connections, and it's been really valuable and really helpful for them.
Thank you.
This is Lauren. I have a question.
Go ahead.
Wondering how we can help other people working with our daughter to understand her behavior. She has had a lot of medical interventions and has associated staff now with painful procedures. And so we're trying to explain to them, please don't take it personally, even if she's verbally abusive, because that's her coping mechanism. I'm not sure what else we could do. I, as a parent, am mortified by some of the things that she says, but I understand where it's coming from. It doesn't excuse it, but it does explain it.
You're talking about people who are not on a DBT treatment team, right?
Right, medical people. She has medical issues as well.
Well, this is a big challenge for. We live in a society that does unfortunately stigmatize psychiatric conditions and doesn't understand them very well on the whole. And I believe it's an education process to try to get people on board and to try to find in your community, every community has those providers, you find through listservs and whatnot, who are more sensitive and more aware, more willing, and maybe more thinking in a DBT kind of way. And
right.
I would encourage you to try to find those folks
that are understanding, but she also requires assistance with ADLs. So we have like home health aides and nurses aides that come in, and nurses to do medication and so forth. And those are the people that are getting the brunt of her behavior.
So, another thing in terms of DBT specifically that we address is any behavior that's treatment interfering. So let me just extend that a little bit. Like, let's say that she was in DBT and she came in and she did that to her individual therapist. Then the individual therapist would target that as a very high priority symptom that needed to be addressed and work with her on what's triggering her, what could she do differently, what skills could she use to get her needs met in a more effective way. Because that often happens with folks who have a lot of emotion dysregulation, that they're so focused on getting their needs met that they alienate people, and then their relationships don't exist over the long haul.
Right.
Yeah, I think there's two pieces to this. I think one is that the caregivers need to understand what emotion dysregulation is. And your daughter also needs to know what behaviors are going to get her what she wants and what she doesn't. The problem very often is that caregivers and sometimes parents inadvertently reinforce those behaviors. So if your daughter screams and yells and the caregiver says, okay, I'm not going to do this right now, I'll do it later, she's been reinforced for that. Okay?
Exactly.
And so those behaviors are going to continue. And so one of the things that you have to look at is not just how the caregivers can understand and accept your daughter, it's also how everybody in the environment has to look at what behaviors are they reinforcing, and even inadvertently, versus what behaviors do they want to be reinforcing to help your daughter learn how to manage her life better. The fact that she's physically ill does not mean that she can be abusive to people in the world. That's just not the way it's going to work ultimately. And so she is going to have to learn that being abusive or being demanding or whatever those words are that you want to use, that it's really not going to get her needs met. If it does get her needs met, then she's getting exactly what she wants. Those behaviors work for her, and there's no reason for her to change them. So one of the things that you have to really look at is what's going on in the entire environment, not only what causes the behaviors, but what maintains the behaviors afterwards.
Thank you.
Welcome.
Another question on adolescence and DBT.
I have a question.
Go ahead.
We had a nice handout that was attached. I'm traveling and I don't have that, but I was looking forward to having some of those specifics addressed. I don't know if Pat has that with her and would like to talk through a couple of those examples.
I haven't. Tell me, you don't have the handout?
I don't. It came attached through NAMI, Florida, and it was attached with the announcement of this call. And I think it had a statement and then something about what was true in the midst of what you're talking about.
Okay, so what we were trying to do is we were trying to help parents learn how to understand what is the kernel of truth of what is going on for your adolescent, okay? And it's understanding that kernel of truth that actually leads to an ability to validate. So that what you're seeing very often is your adolescent, screaming and yelling and saying things that turn you off and that make you angry and that make you frustrated. But what happens if you can actually look at that behavior and say, what's going on? Okay, to say to yourself, what's going on with my kid? They had a really awful day in school. So, for example, your kid comes home and says, I'm a total loser. I don't have any friends. I don't know what to do, okay? And the issue is your kid's not a loser. And most parents are going to say, you're not a loser. And that your kid's going to get angrier. And you're going to stand back and you're going to say, wait a second, I'm saying you're not a loser. But for your kid, they're not being heard. And so part of what we want to do is we want to figure out what's valid under that statement. And any kid that comes home and says to a parent, I'm a loser, is really trying to say, I'm feeling really, really awful. Okay? Something's going on that I'm feeling awful about myself. That would be the kernel of truth. Okay? And so what we have to do is be careful to sort of try to understand what is going on underneath, and to ask the adolescent, it just looks like you're really angry, it looks like you're really upset. Is there something going on that you want to talk to me about, or is there some way that I can help you feel better right now? Not to necessarily jump in, but to say I'm available when you're ready to talk about it.
Let me just add to that. The nice thing, and really that's kind of what we wanted to focus on today, is validation skills. And the validation is really the acceptance side. So a lot of times as parents and sometimes even as therapists, somebody comes in and we want to jump right to the solution. And yet when somebody's emotionally dysregulated, you can't get there. They just need to sort of get their emotions down to a level where they can think logically and strategically again. So, for example, the child comes home and says, I'm a loser, and a parent being validating might say, well, what happened today, and tell me what happened. And then the validating statement would be like, I can understand why you feel like a loser. That doesn't mean that you agree that the child's a loser, but it's saying, I understand why you would feel the way you're feeling. That's a validating statement. And then typically if you hit a validating statement like that, it makes sense to me that you would feel the way you feel given X, Y, and Z. Then the moods come down, and then you're able to jump in there and do more strategic problem solving. So that searching for the grain of truth or the kernel of truth is looking for what in this big global statement does make sense. What can you validate in that whole statement that an adolescent makes that triggers you as a parent or as a therapist or a family member, and find that one little thing, validate that, and then you're going to start seeing the mood come down a little bit. But it's a little labor intensive. It doesn't happen in 2 minutes. It might take 8 minutes or 10 minutes to get to that point.
And it may take even longer to figure out how it is you can acknowledge your adolescent in a way that your adolescent feels acknowledged. Okay? So that's also idiosyncratic, and it's very hard. And I know the parents that I work with sort of say, well, I'm trying, Pat, I'm trying to validate. And yes, the parent is trying to validate. It sometimes is real trial and error, and it is labor intensive to be able to figure out how can I help my kid really, really realize that I genuinely am trying to understand, and that I get the fact that there's something very serious being said here.
One other thought on this is that one of the theories of borderline personality disorder is that some people are born with a more intense emotional system and a higher level of reactivity to things in their environment, and that when they have these high intense reactions, it can be sort of baffling to those around them, who then respond with inadvertently invalidating remarks. Like, what's wrong with you? Why are you reacting so strongly? Why are you being such a drama queen? Why are you carrying on like this? And that is confusing to folks who actually have those very strong emotions when people are telling them ostensibly these emotions don't make sense and it's ridiculous to be having them. So this piece of validation is targeting that. It's really addressing, okay, I get that you have intense emotions, and I get that given that you have intense emotions and that X, Y, and Z happen, that you would be upset. Now, where do we go from here?
Hi, this is Ray. I have a question.
Go ahead.
I have a 14-year-old who thinks she's been in therapy her whole life and is burned out. So you have to make an investment in time for DBT. Is it still beneficial if she only finishes part of it, or you do pieces at a time? We would have to drive an hour and a half one way to get to the only place in our area that has it, and I can't get her to commit.
Well, so that's a very good question, and unfortunately that breaks my heart that it takes an hour and a half to find a DBT provider. I think that's not uncommon, unfortunately, throughout the country. The beginning phases of DBT are really focused on commitment with the young person. As you can imagine, the parents are usually much more bought into it at the first session than the young person is. What's so great about DBT, though, for adolescents is that it's a completely transparent and collaborative treatment. So there's nothing being done to anybody that isn't fully explained and totally available, from multiple sources. There's no secrets in it. So we have found, and anecdotally, when I talk to other DBT therapists that work with adolescents, that adolescents really respond to this kind of open, accepting, and collaborative approach. And sometimes they find it a refreshing and surprising change from therapies maybe that were more coercive or more authoritative, that were less directive than they've received in the past. So I think you'd have to go see the therapist and see how you get going with that commitment phase. We don't really begin DBT in earnest until the adolescent has committed to the treatment. We ask a lot of adolescents and parents in DBT. They're expected to fill out daily tracking tools that monitor their moods and behaviors every single day. They're expected to call their therapist when they're in a crisis. And if they don't, we would target that as treatment interfering. They're expected to do homework and bring that homework to their skills group and share it. So there's a lot there. But that's one of the benefits of all the CBT research is that homework and extending the information that you're learning in your therapy session outside the session is correlated with better results.
I also think I just want to sort of repeat what Britt said. DBT is also not this is what we're doing to you. Okay? Those of us, first of all, the relationship is of utmost importance in DBT. And there has to be a relationship. And actually a lot of the change occurs through the relationship. But I think the other thing that's important to know is that those of us that practice DBT, we practice DBT. We don't just practice DBT in our clinical lives. These are skills that, for me at least, they've changed my life in a lot of ways, and I don't have BPD. So when I talk about DBT, when Britt talks about DBT, it's actually from the experience of using it. And unlike in other therapies, we're willing to say to a teen, or for me to say to a parent, this is how I use the skill, and this is what it's done for me. So this is really upfront. It's really engaging. It's really a collaboration between the therapist